So good morning, everyone. My name is Singh. I'm a technical manager as part of CHAI's Global Vaccine Delivery Team. I'm really happy about this topic today. I think actually the team has done a great job in connecting all of our presentations. So I think it's going to be very natural as we talk through some country examples today. As I said, I've been really looking forward to talking more about optimization and prioritization. Or specifically vaccine optimization, prioritization, also known as VPOP, which has become a little bit of a buzzword, but I think probably by the end of the day, it'll become part of all of our vocabularies. So after taking a look at the recent Munich data that came out earlier this week, I think we can all agree that all the investments that have been happening in immunization have led to great results. However, some of the things we talked about yesterday for folks who were here, what is left behind is some of the most expensive work that we need to do in regards to zero dose, equity, vulnerable populations, in fragile settings. And unfortunately, we're in a situation where global aid is in a very different environment, and we're probably moving away from what we maybe didn't realize was the golden age. So now the question is, what do we do about that? And it's not all doom and gloom, I can promise you that. So the challenge is really that efficiency is no longer an option, it's just something we need to do. And so one of the clear opportunities to do that is through vaccine portfolio optimization and prioritization. We'll get to a little bit more detail as to what that definition is. I think the other part, which a number of speakers have already noted, is integration. So why is immunization paying for everything where we could actually be integrating a lot of the smaller resources that we now have? So today I'm really excited that we're going to have a great panel to actually talk about some of the examples of countries who are not only thinking about this, but have already started doing some of this work, and how can this be thought about for other countries as well. And we'll hear from Nigeria, Kenya, Indonesia, very different situations, so I think provides a lot of great examples for other countries who are having to maybe get on that highway and go pretty fast on how we can do opportunities to optimize. So, as I said, we'll hear from them through panel discussion, but before we get there, I want to invite my colleague Anitha Athiyaman to give us a brief overview on the macro trends in aid efficiency. I think others, USIP colleagues, present that very well as well, and just why optimization, vaccine optimization really matters now. So Anitha is a technical advisor, also part of the Global Vaccine Delivery Team at CHAI. She's worked with a number of countries over several years to support immunization coverage and equity, and also optimization. So I will come to the stage.
Thanks, Nav. Hi, everyone. Good morning. It's very nice to be here with you. I think it's a good segue to the last two panels around financing outlook. I think the remainder of the day is going to focus on this theme around efficiency, prioritization, and vaccine portfolio optimization. And in the next 10 minutes, I'll try to paint a broad strokes, try to simplify some of these complex and topical topics to drive home a couple of key messages before our country panelists come here and share their specific experiences and best practices in leading some of the optimization and integration work. I want to start by saying, and I think this is not new, today's aid politics is very difficult, and the global health environment is shifting rapidly. I think we've heard about this in the last couple of hours, but while it's scary and certainly difficult for a lot of us who work in the sector, but also for those who that we serve, I think it presents an opportunity to drive some long-term changes in the global health architecture. Some of this is long time coming, right? And I really like how Daniel from Ghana presented this morning. A transition is not an endpoint, but a systems transformation catalyst. So that brings us to the need for technical efficiency. So the previous discussions focused more on allocative efficiencies. We're now talking about how do we do more with less. And this could be by reducing costs, it could be integrating service delivery, but being more efficient in how we extend services to the populations that we serve. And this is not new, though, right? We've braced for this and actively worked towards it in a lot of countries under the themes of sustainability. We've talked about Gavi transition over the past decade. but also more so since COVID-19, where the economic growth has kind of slowed down. I think countries are struggling with limited fiscal space and high inflation rate. They're experiencing this dual interplay of like macro aid pressures, but also like limited domestic health financing that's really accelerating the voice for efficiency. Particularly in immunization, we've seen some trends that broadly favor prioritization and optimization. So through Gavi support, countries now have an expanded option of menus. So a lot of countries currently have 6 to 7 new vaccines on their portfolio. They're looking at probably expanding to 10 to 19 eligible vaccines in the next 5-year period under Gavi 6.0 strategy. There's also been incredible advancements in supplier diversification and innovation, right? So if we look at PCV vaccines against pneumococcal disease, in particular, we've moved from 2 suppliers to 3 in 2020 to looking at more so in the next 5 years. This also offers some low-cost options for vaccine procurement. And relatedly, choices are also broadly expanding, right? There's diverse presentations of vaccines, which kind of favor ease of delivery, thermostable storage, but also varying schedules for countries to choose from. So Gavi current market offers more than 50 possible choices of vaccines for countries to choose from, and based on their local needs. And as we also expand new vaccines, there's also an increasing number of life course touch points. This presents services that possibly could be extended to pregnant women, older adults, adolescents, a natural opportunity for considering integration where our immunization services did not have previous reach. The complexity is increasing, but also the opportunities where decision making can be centered around optimization and prioritization. So that brings us to today's discussion over the next couple of hours, centered around 2 of the high impact levers for efficiency. One being optimization, where a country can assess new or alternative vaccine options. It could be products or brands, it could be presentations or choice between a 5-dose versus a 10-dose vial, a liquid versus a frozen presentation, or a schedule, so HPV on a 1-dose versus a 2-dose schedule, or use cases like fractional dosing for polio. And the choice to switch to these optimal options in a country's immunization portfolio. And the second one, which we've heard a fair share over the past day, is around integration. So how do we approach immunization program planning, policy, service delivery, and management in an integrated manner that promotes the broader goals of equity, coverage, and sustainability? So optimization is not new. This has been happening across countries, but to date, it has been more reactive and sometimes focused on single antigen markets, mainly driven by global factors. But we see the world where we're going forward into, there might be more momentum to drive these optimizations from a systematic and portfolio lens, where country stakeholders are equipped with the right tools, capacities to drive evidence-based decisions on a routine basis. The focus will start to shift, and we'll hear more about this on the presentation from Gavi, on saving costs for procurement and delivery, prioritizing market health as we shape country demand with a lot more intention, and build local capacities for evidence-based decision making and implementation. So today on the panel, right after my presentation, we'll hear from our ministry representatives from Kenya and Nigeria about the recent PCV switches, where they've moved from an existing vaccine product in their portfolio to a low-cost PCV product that saves millions of dollars in total procurement costs per year. These are both countries in advanced stages of transition out of Gavi support, so they have a keen eye on unlocking efficiencies in programming. So Kenya was an early adopter of the low-cost product, and Nigeria being the most recent one, but also a forerunner in their own stride, where they conducted similar to Pakistan, an optimization exercise to open up fiscal space for other new vaccine investments. And this is the last point I want to make before I wrap up, is on integration. So this moment of like aid volatility has presented a renewed call for integration of immunization services with other primary healthcare. I think over the last couple of years, there's like increasing evidence on like why and how integration can work in mutual benefit for immunization and other broader health outcomes in different settings. There's some really incredible examples coming out of campaigns, especially in driving down costs per service delivered. I think there's an estimate from Nigeria where in one state they were looking at the economic delivery cost of like a standalone yellow fever and MNA campaign around like $7 million, while an integrated campaign can bring that cost down by $2 million. I think I might make a stretch here and claim that like this time is like less so in questioning the why like integration matters, but more on how do we like use this as an opportunity to scale the models of integration that work, and rooting them in some key principles around leveraging programs that have good synergy. So this could be population target, this could be service provision, like service providers, or the timing of delivery, considering context-appropriate interventions, leaning into the learn by doing approach where we iterate based on emerging data, and considering like how best to scale and sustain these integration solutions that do really work. So in conclusion, like it may be an unprecedented time with the macroeconomic shifts, but it could also be a catalyst for long-term changes. And I hope that we continue to see the opportunities for favorable changes. Thank you.
Thank you, Anitha. So we're going to invite our panelists up here. So as I said, we're going to hear from 3 key countries, so Nigeria, Kenya, and Indonesia, about how they've already started to take advantage of some of these optimization opportunities and integration. So first off, I'm going to bring back up Dr. Rose. As Laura said, she's head of Kenya's National Vaccines and Immunization Program, has led the introduction of many vaccines, so I'll invite her up. And then secondly, I'm also very happy to invite Dr. Bakunawa, who is the Deputy Director at the Disease Control and Immunization at NPHCDA. So he currently serves as the Country Assess Officer for Gavi Investment, has led the new vaccine strategy task team, and also their 10-year immunization strategy, as well as the recently developed FPP. And then lastly, very happy to invite Professor Auliya, who is the chair of the Indonesian Health Technology Assessment Committee and a member of the Health Economics Working Group on the IHEA. So I'll invite my great panelists and pose a question where they can share their reflections on how their countries have gone through some of these optimization and integration opportunities. So, Dr. Rose, I'm going to start with you. So Kenya, as Anitha said, was one of the first countries to adopt the lower cost PCV-10 product. It would be really great to hear sort of what triggered that in the country and what that process looked like for Kenya to think about that decision, but also go through the process of actually making that decision.
All right, thank you. So maybe to start, Kenya was an early adopter in PCV-10. We have a general target population of the surviving infants of around 1.5. So the switch was from PCV-10 manufactured by GSK, it was 4 dose, to Pneumocil manufactured by Serum Institute, which was 5 dose. And then we received a grant from Gavi to switch at 0.25 per child. So of course there were total savings in terms of the switch. So not only the cost, but we also, at this particular point, is a point where we knew that we are going to get into the accelerated transition phase. And then it's a point where we knew that we'd introduced multiple vaccines, and we are planning to introduce additional vaccines. But again, the storage space at the health facilities was constrained. So again, this was an opportunity for us to sort of rearrange vaccines within the cold chain space, and there was an additional 20% storage for the switch. We can go to the next slide. Yeah, so in terms of how this process looked like when we were presented with the opportunity, we have to go through the decision-making processes. So we had to discuss it in the technical working group to look at the programmatic aspects, and then we posed a question to NITAG and they used a recommendation framework to be able to review the evidence or about the switch, and also they reviewed other factors that favored the switch of the product. So once NITAG had written a recommendation, the Ministry of Health adopted the recommendation, and that subsequently led to the switch supported by Garba. So in terms of the switch, we had to do training of the healthcare workers because there was a change in formulation from the 4-dose to the 5-dose, and then subsequent change of materials for them to be able to know how to manage the vaccine. So it was a one-off capital cost investment, but again, remember, it created a lot of space in the cold chain. And again, in terms of the waste that came from the secondary packaging, there was reduced waste production after the vaccination. So we did the switch in 2022 across the country. So in terms of every time we introduce a vaccine, so PCV was introduced in the country in 2011. So every time we introduce a vaccine, we have our research institutions that do the impact analysis on the burden of disease as a result of introduction. So what PCV, then the PCV from pneumococcal, what the data from our research institution had shown us is that the additional serotypes that were in the pneumococcal were actually the prevalent serotypes in the country that causes invasive pneumococcal disease. So again, the pneumococcal came with an additional advantage of having 2 serotypes that were not in the GSK original PCV10. So those are some of the considerations we looked at in terms of the switch, which is used by the NITAG to be able to make a decision about the switch. So this allowed us to plan for more vaccine introduction and also have less cost in terms of the PCV, but again, in a position to introduce more vaccines in our vaccine portfolio.
Thanks, Dr. Rose. And actually so moving on to sort of Nigeria and Dr. Bakunawa, we actually saw that Nigeria adopted a similar decision on switching from the GSK product to the pneumococcal product, also from PCV10 to PCV10. But we saw that with the FPP, the country looked at not only switching, but switching to potentially look at new vaccine introduction. So yeah, be interested to hear how you not only looked at optimization, but looked at optimization and prioritization as part of the country's priorities.
So thank you very much. So thank you very much. So for Nigeria, so we look at it in the different contexts. So like our brothers from Kenya, so you switch the product looking at opportunities to also introduce other vaccines. So the same thing also we did in Nigeria. So you recall that Nigeria recently we introduced malaria vaccines, and at the same time also we have cases. If you recall, one of the maps that was shown, we have a lot of also BPDs outbreaks in the country. So most of those BPD as well are around measles, as well as also we have also MenA, that's meningitis outbreak. So for us as a country, we look at it in the context of also introducing some vaccines. One, the burden of malaria is very high in the country, so we want to introduce also malaria as a vaccine. Then the other component, we are also looking at switching the product for the meningitis. So currently we have MenA that is there, but most of the outbreak we see the serotype, different serotype, which is MenC, that is causing the outbreak. So because of that, we are also looking at changing the MenA from MenA to Men5. So Men5 has additional serotype which includes C. Then at the same time also we realize that from the outbreak of measles that we have, we also realize that also the burden of rubella is also there. So we are also looking at introducing MR instead of looking at just the measles vaccine. So based on those contexts, so we realize that we have also a very tight fiscal space. So what can we do? So we now look at optimizing the vaccines that we have, that's the portfolio vaccines. So in that context, from the new vaccine, we have 2 categories of vaccine that we procure in the country. We have the traditional vaccine that is 100% supported by the government, federal government. Then we also have the new vaccine that is co-financed between Garba and the government of Nigeria. So we look at the vaccine in the new vaccine schedules, we realize that like PCV, the cost for PCV is more than like 50% of the co-finance that the country also, provides. So the best way is to look at, do we have other option product that can also provide an equivalent that is protection like the GSK, just like also Kenya. So we're using the that is PCV 10 4 dose by GSK. So we look at what are the other options that we have. So the best one that we look at is actually to the SII that is a product, which is we also consider the 5 dose. So that was how we arrived at the decision. So first of all, we have to also have a wider consultation in country with the stakeholders to agree what is the best way, at least to achieve that. So this is the profile that we have as a country. So we look at our population size in terms of the target. So, and these are the product that we agreed to also take, switching from 4 GSK to Serum Institute product, which is 5 dose. Then we look at also the cost per child, which is there. And if you look at the amount that we are going to save cumulative from between 2025, we are introducing this year. We are yet to introduce, but we are already in the process. So we are introducing, switching this year. Then by 2030, the country is going to save over $196 million from just PCV alone, so which is a huge amount. And that will help us also address some of the gaps that we are seeing in terms of the MR switch, as well as also, even if we are able to achieve the main A, that this switch will be able to achieve that. So, and of course, the country also liberated the platform that we use, looking at the review of the entire the Gavi portfolio using from the FPP. So one of the components that we actually discuss and agree is around the new vaccine introduction, which is part of one of the main objectives of the entire portfolio review. Then we have also a lot of technical conversation. That one start actually from the need analysis that was done by the technical team, looking at the disease burden and also some of the consideration. Then the other aspect is also the working groups. So we have different working groups, from the routine immunization working group, national logistic working group. We have also new vaccine strategy testing, which has the mandate of reviewing all the vaccines that we have, including the switches. Then we also have vaccine financing and accountability testing, which I can see some of our members here. So the function of that particular working group is to ensure that on a regular basis also we monitor the consumption of the vaccine, as well as also the availability, the utilization, what are the gaps, then at the same time looking at the vaccine financing. So those are those regular meetings. So all those tasks, teams, they are actually strategic in taking decision. However, the approval has to go through 3 major important components. One, we have the recommendation, because we can't switch without going through the NITAG. So we have NITAG provide the recommendation. Then at the same time, the recommendation has to go. Unlike some countries, I realize that they have only from NITAG, it has to go straight to the ministry. But in our own context in Nigeria, we have National Primary Healthcare Development Agency, which has the mandate of vaccine introduction. So from NITAG recommendation, it will move into the core group, what we refer to as core group. So the core group is another technical body, which is higher. It's chaired by the MTSCDA Executive Director. Then we also have all the head of agencies managing immunization program. For instance, like the UNICEF, we have the immunization manager in UNICEF, WHO, the same thing, CHI, and all the other partners that we have in country. So they take decision. So from the technical, whatever comes from NITAG, it has to also come to be presented at before it reaches to the minister. Then from there, we have the final approval by the minister. So for the PCB, those are the process that really take place. And for the FPP, other technical working group, as well as also through the NITAG, and also through the core group, and also finally approval by the ICC. So those are some of the enablers that we are looking at having sufficient technical resources to really conduct necessary costing analysis. So for the costing analysis, there are levels. So just like you said, we have some preliminary engagements by the Vaccine Financing and Accountability Tax team. We have our partners that are also part of the team, so they help us to do some cost analysis to look at some of this. And we also engage the NITAG. The NITAG also has a body, so whatever we have, we work together. Then the country also engaged some private firms that also supported to do like Peros. They supported also in doing some deep dive around the entire vaccine for polio to look at the finances. So all those things were done. The visibility around the new product availability in the countries and the experience of other countries. I believe we also check what Kenya did. Also, we actually work with our colleagues, especially Chai. The Chai, both our in-country team as well as also the global team. Most of the cases around the vaccine introduction, they really provide a very good assistance around the technical support, analysis, looking at experience from other countries. So we work around them to ensure that at least we have a very good decision around the product, and that's how we arrive at that decision by the council. And presently we are developing the training materials for the introduction, for the switch. And at the same time also we are looking at having a very successful So you discuss also integration. I know maybe there may be question on that integration, but the idea that we have started that integration long ago. So many things around that. So maybe when we come to conversation around that, maybe we'll provide some update. Yes, slide. So thank you very much.
Okay, thanks. So moving to two accelerated transition countries to a country that has already transitioned, so a little bit of a different experience. So Auliya, it'd be interesting to hear from the Indonesian perspective. The country, has already transitioned, has had to go into a very different fiscal space, and also has been looking at VPOP, an acronym that everyone will remember very soon. We'll also look at integration as well. So it'd be great to hear the Indonesian experience on how you have found efficiencies in being a slightly different archetype country, as well as looking at integration as well.
Thank you. So in Indonesia, the Minister of Health have been shifting the priority from curative to preventive and promotive since couple years ago. And in terms of vaccination program, the government has been trying to include more new vaccines into the national immunization program. But the challenge is how can we afford? So as a country, we feel very lucky that Indonesia is being involved as a piloting country to develop a prioritization tool, namely capacity. So during the development, we gave so many feedback to WHO as the developer. So in the beginning, we used the tool to prioritize among antigens. And then once we finish the exercise, we give the feedback to WHO that if we can compare or if we can prioritize all new vaccines that we are going to introduce in the next couple of years, that will be very beneficial. And we felt so lucky that WHO at the end facilitated our idea. And then we did exercise. We compare for new proposed vaccines at that time, rotavirus, PCV, HPV, and Japanese encephalitis. So in this case, we prioritize 4 new vaccines in terms of developing comprehensive multi-year plan for the period of 2020 until 2024. And then we also use the same tool to prioritize more new vaccines in terms of developing national immunization strategy for the period of 2025 until 2029. So we compare 5 vaccines, dengue, TB, typhoid, influenza, and malaria. So again, the problem in Indonesia is we have concern about the cost effectiveness value, but the most important part is how can we afford. And then optimizing the use of capacity, we also can provide several scenarios. So for each vaccines, we develop at least 3 scenarios for the introduction. Let's say the first one is the most optimistic, and then the second one is less optimistic, and then the third one is least optimistic. So we combine those 3 scenarios, and then we simulate in the tool. So at the end, we can conclude not only which vaccine can be prioritized, but also we can conclude which scenario that we can prioritize. So I think so far the general overview that we can share. Yeah. Sorry for the last slide. Okay. Yeah. About integration adapted at local service delivery level and also with rotavirus vaccine introduction. So maybe I want to add some additional information. So we have around 12 criteria in making prioritization, and then I want to mention 2 unique criteria that maybe it is relevant in Indonesia, but may not be relevant in other countries. So we added 2 additional criteria. The first one is potential local manufacturing, and then the second one is vaccine availability. So we made those 2 criteria in separate criteria because the fact that local manufacturer already has a privilege to support our vaccine, but the second thing is about vaccine ability. They also have to make sure about this aspect. So we already put those 2 criteria in our prioritization tool, and if you are talking about rotavirus or other vaccines, again, it is a living document, so even we can update it in the future.
Great, thank you, Dr. Ali. So I think I have one question to the group, and then we'll put it out to others. I'm sure you have lots of questions. Actually, Prof. Auliya, on what you've mentioned about the capacity tool, sort of a global resource that is really helpful in your country. And I think Gabby and others will comment on sort of their approach to VPOP and potentially other things that could be leveraged. And I think we have a session later on specific tools, but reflecting on your country experience and the process that you went through. What other global resources or engagements do you think would be useful now that VPOP is going to be more of a regular process potentially that countries are going to have to go through? So you mentioned capacity framework, maybe product visibility. Are there other tools or resources or assistance that you think would be very useful for countries to be able to do this on a more regular basis?
Since the basis of capacity tool is MCDA approach, so and then we also adopt this approach not only to prioritize new vaccines, even we also use this approach to prioritize new healthcare intervention to be in Indonesia. So in terms of support from strategic partners or institution or organization, I think if you are if we can learn our challenge, our biggest challenge is if we want to adopt a new program, specifically for new vaccination program, we have to make sure that our healthcare system can afford this. So in terms of health economics perspective, if we can explore more detail about innovative financing mechanism, for instance, I think support in this area will be very essential for the country.
Okay. Dr. Rose, same question. What kind of resources do you think would be useful? Thinking about the process that Kenya has already gone through, but probably needing to go through even more in the future.
I think one of the things that we learned in the process is strengthening of NITAG members, NITAG, in terms of decision making. So again, just getting from evidence to implementation of the switches.
So because with this, the kind of support needed is especially the strengthening of the capacity, because we have members coming into the NITAG, others transitioning out. So continuous capacity building and also support for these meetings in terms of reviewing evidence, the budgetary costs, and everything. So strengthening NITAG has been one of the lessons we've learned required to complete the process.
And then from the Nigerian perspective as well.
Yeah, thank you very much. Mine, based on the experience so far, I think those areas that we needed in generally is around the also the capacity, but not looking at the technical teams and others, but how we can also expand the scope of our stakeholders. For instance, for vaccine sustainability, maybe vaccine financing, as well as also maybe around the releases and others. So the engagement of other stakeholders is really critical. Ministry of Finance, Ministry of Budget and National Planning to ensure that the courses of vaccines, that the funding for vaccine is actually prioritized, that prioritization because it's good. Then the National Assembly, because they are also very, very important, and then so the capacity building of the other stakeholders beyond health, I think, is very, very important. That would help because most of our decision, if you look at it, is around whatever whether prioritization, switch, new vaccine introduction, is still boiled down to resources, which is funds. So, and those funds, we only work on them and request. But in terms of the releases, as well as also in terms of the making sure that that funds is available, is actually beyond the head, but look at other line ministries as well, and also the National Assembly. Then maybe looking at also some of the policy issues, sometimes those policy changes, they are also very, very critical. So those are areas that I think maybe as for us as a country, I think it will go a long way to do some of the things that we do. Then the other aspect also is the cross-country, exchange, learning, exchange. Before Gavi supported, BMGF supported aspect of learning hub for countries in transition, supported. So that one also helps us. Those kind of platforms, they also help. You see what other countries are doing, they can also help. Like Ghana, they are just very close. They are just like a state close to Nigeria. So for Ghana, they are also using NHI. So I was wondering, because for us, like if you look at what we give for the component of NHI, is just like a fraction of the vaccine. So I can see like Ghana, they are using NHI also to fund some part of their vaccine. So those kind of learning exchange are really very, very critical. Okay.
Yeah, I think Idris referred to as the big brother, so sibling exchange is needed. Great, so I'll actually open it up to the floor to see if there's any questions before we wrap up.
Thank you for the nice presentation. So this is finally from Bakunawa from Martin. You mentioned that in case of Nigeria, the NITAG makes a recommendation, and then it goes to the court and then it goes to the ICC. There are 3 layers of decision. So is there anything that the NITAG recommends that's not approved by the core committee or ICC committees? Thank you.
So just before the mic already. Okay. Hi, thank you everybody for this very stimulating discussion. My name is Eve Worrell. I'm a professor of health economics from Liverpool School of Tropical Medicine. I had a specific question for Dr. Bello on the decision to shift from the 4th to the 5-dose vaccine. Did you consider challenges in terms of receiving the 5th dose for children, which we know, the number of doses is really, and there's quite a lot of evidence coming out of the malaria vaccine studies now that shows, well, we've got really quite high coverage for the 1st dose. By the time you get to that 4th dose, it's very low. So I'd be really concerned about cost effectiveness and health impact. Obviously, we need to optimise the budgets, but to what extent are those kind of effectiveness decisions weighing into the sufficiency agenda?
Thank you. My name is Auliya Suwantika from China, Nigeria. My question is for the Indonesia team. really want to learn more about the service integration at service delivery level. I think that's something that I would want to learn more, especially around how that has an effect on the human resource core health need, at that lower level, and how that potentially has an implication on saving some of the costs, that is being expended at that level.
Thank you so much for the presentation. My question is about the interaction or interfacing between the VPOP process that was presented earlier and the NITAG work, because you all mentioned capacity of the NITAG. We do know that one of the issues for NITAGs is the secretariat, the strength of the secretariat. And I consider that the NITAG becomes really, we can see that the NITAG is an impact factor when it has said no to the government. It seems to me that a lot of NITAG keep saying yes. Isn't that they don't really have materials to discuss? And if they are not so strong as we are saying, how do you see the VPOP process in that NITAG? How are they going to work together? Do you have experience on how they have been feeling into it? And can you share that discussion in the case of Indonesia? And my last point is about the status of your respective data. Could you share about from Kenya and Nigeria, for example? What do you think about the NITAG capacity to advise the government at the moment? Thank you.
Okay, thank you very much. My name is Auliya Suwantika from NITAG Nigeria. So my question will go to Kenya. Looking at the best practices of vaccine introduction. And Kenya just gave us a very good best practices, a success story about some of their vaccines that they've introduced in their country. Thank you.
And then the last one from Logan.
Yes, I recognize that the cost savings that you're projecting is a savings to the government, but is it a savings to the program? And I ask that question because of how program is generally financed. That you have to make a request for resources. It's not that the money is going to sit somewhere in an EPI account, right? It goes back to the government. So what sort of mechanisms or what is the thinking about how to maybe earmark some of those resources for the program so that you can benefit from that reallocation?
Great. Go back to
So thank you very much. So the first question has to do with the okay. Thank you. So on that decision, of course, we have multiple layers, like three, just like you mentioned, but that actually doesn't really affect the decision. For instance, in most of the cases, what all the recommendations so far that have been provided by the NITAG really pass. So the core group, the function of the core group is actually like a kind of they look at the review whatever counts before it reach the minister. You understand? So from the recommendation of the NITAG, it comes to the core group. Whatever NITAG recommend, usually core group doesn't change anything. So they just take note of that as a technical working group, because most of them, they are also members of the ICC. That's for the final approval. So they just take note of those recommendations, but they don't change the recommendation, and they don't delay the dissemination or the relay of the information from the NITAG to the minister. So it's actually not a bottleneck for that. You understand? It's just like the structure, the way the structure is. So decision has to pass through the core group before they reach the Interagency Coordination Committee. That's the ICC, where the minister really provide the final approval. They usually really don't delay. Then the second question regarding the from 4 doses to 5 doses. It's not actually in terms of the number of shots that the kids receive, but it's the formulation of the vaccine. So the vaccine that we used before is the PCV 4 dose vial. So the one that we are now changing is still PCV 5 dose vial. So the difference is in the number of the doses in the vials, not the schedules of the children. So the schedule doesn't change. It's still 3 doses. We give them PCV1 at the 6 weeks, 10 weeks, and 14 weeks, the third dose. So it doesn't really affect the doses that the children receive. So in terms of the NITAG capacity to advise the government, so really for us as a country, so the NITAG is made up of really experts. They are professors, they are resource people that are really distinguished in their own capacity, and they cut across all the components of the immunization and also from academia. So in most of the cases, they work independently, and whatever decision they provide, nobody can change those decisions. They hardly being influenced. I agree with you in most of the cases that whatever we ask, they usually, work. So they usually analyze, but we have an instances in Nigeria whereby these are some of the things that we want, but at the end of the day, that wasn't what the NITAG really provide as a recommendation. And we have no option because those are people that we cannot change their decision as government. So whatever recommendation, we also respect them as experts coming from different, backgrounds. So we respect them as experts. So we don't change their decision, and they work independently. The only thing some of the technical team does is actually provide that secretarial support, just like you say. So the strength of the NITAG is around that, all those search and all that is support the NITAG. But in terms of the decision, whatever decision they provide, usually is well respected as a country. And there are so many instances as a country, especially for HPV, before we arrived where we were. So there were a lot of things. So we started so many things, but at the end of the day, still they insisted. For instance, initially the country wanted to go with Innovas as a product because of the cost. But the decision of the NITAG, they now provided the decision that we should go for Gardasil because of some other advantages that they have seen. So based on that, we have to go with their recommendations because those are not people that you can influence. So their decision is actually independent and is very, very strong and well respected by the government. So in terms of savings that you mentioned, so the saving is actually to the government, not to the program. But we look at it in the context of when we have the savings, those savings come with the recommendation from program that, okay, we are working toward having savings in this component, and we are also leveraging to use those savings to improve at maybe by introducing other new vaccines, also looking at also product switch, like we have for new vaccine like malaria, just like I earlier mentioned. For new product, we are looking at MR instead of the measles that we use, and we are looking at using MEN5 because of the serotype C instead of just MEN-A. So those are some of the things that we look at. So as program, we provide that. And another thing beyond that, the savings, most of those countries, developing countries, some of us, we are also struggling even to pay for the co-financing. So by the time you have the savings to go also into providing like funding for the co-financing, even if you cannot introduce, so you are always struggling to see how you can pay for the co-financing. So in that situation, when you have the savings usually move into that, and there are a lot of conversation before you arrive at that savings. So therefore, whenever you come up with a suggestion of how you can also use some of those savings, usually the government also understand that, and they can also support you in that aspect. Yeah.
So I'll speak to the NITAG, how the NITAG operates. Yeah, so in Kenya, the NITAG how it operates, it has the 12 expert members drawn from different fields. So we have pediatricians, physicians, and we have a legal member within the NITAG. Then we have the liaison members, ex-official members, and also the secretariat. which is basically hosted within the immunization program, but can be drawn from any department within the Ministry of Health to support. So depending on the topic of discussion. So for instance, we've drawn membership from the disease surveillance, we've drawn membership from Ministry of Education, Ministry of Agriculture and Veterinary Services, depending on the topic of discussion at that particular point in time. So normally what happens is that before they are presented with a question, and then they form different working groups in order to deliberate, and with the lens of evidence of framework. That's a tool they use in terms of decision making. So the secretariat's role is to provide information and facilitate their functioning. So in terms of the final decision, it's not made, the secretariat does not make the final decision, but it's the core members that make the decision, and they normally vote based on the discussions that have been made. So once they make a recommendation, and a recommendation does not come as a yes or no, so normally it has a pro and a con, and then it has some of the things. For example, if they say we recommend this vaccine to be introduced, they can say that before it's introduced, the government should consider strengthening these other aspects before the vaccine introduction. So again, it's within the Ministry of Health to either adopt that recommendation or not, or at times, again, gives feedback to the NITAG. So in that sense, that is how it operates. But again, over the time, even as we've discussed, there are several things that have been discussed in the NITAG, we've received a lot of feedback from them, so that currently we have other members who are not previously part of NITAG. So for example, the Ministry, National Treasury, Finance Officers, Health Economists. So this has been necessitated because of the growing landscape of immunization, and also in terms of the discussions that need to be based on the looking at the overall health system funding landscape vis-a-vis the immunization funding landscape alone. So the other thing in terms of savings to the program, so we do not have, so I can look at it like a direct saving to the Ministry of Health in terms of, for example, the PCV-10 gave a 35% reduction in terms of the total financing costs. So that is to the Ministry of Health. So and then, so into the program, I look at it indirectly, so that if there's an opportunity for vaccine optimization, instead of the program looking at how to increase the number of cold chain equipment, it's already been created through that vaccine optimization platform. So look at it, the program is going to benefit indirectly, but that money is not going to come directly to the program. The other way the program can also benefit is that when they start cost saving, it's taken to the VII, Vaccine Independent Initiative, again, which can be used to do in-country logistics to support the program. So it may not be a direct financial benefit, but the program does benefit from this. And then the last one is on the multiple vaccines that Kenya has introduced over the last 2 decades. So in terms of the best practices and what we've learned over time is that one, what is key to successful vaccine introduction that we've learned over and over is multi-stakeholder engagement in any vaccine introduction, again, based on which type of vaccine it is, in engaging multiple stakeholders and also engaging the community, and a facilitative environment, especially from the political leadership, facilitates successful vaccine introduction.
I want to answer 2 questions. The first question is about how we can make immunization service delivery to be more efficient. So using the Indonesian experience, I can share 4 key points. The first is effective scheduling, and then the second one is how to enhance the collaboration between public and private healthcare facilities. Because in Indonesia, it is very important to strengthen this collaboration. And then another thing is about collaboration between local and central and local government. So in terms of sharing resources, including budgeting, I think in Indonesia it is very important. And then the last one is using a reliable supply chain management. So fortunately in Indonesia we already have a well-developed system. So I think in this case it can make the supply chain management, including immunization service delivery, to be more efficient. And then the second question is about how NITAG can make recommendations. So talking about the structure of Indonesian NITAG, so we have NITAG core team, and in addition we also have our economic working group. So in general, both of those two systems work together in terms of NITAG making recommendations. So NITAG core team will focus on safety, efficacy, and quality about the new vaccines that will be introduced. About the recommendation, core team member will focus on that area, and then for health economic working group, we will give feedback in terms of cost effectiveness, in terms of affordability, and step-by-step scenario from the health economic perspective.
Thank you. I think we have time for maybe one or two questions.
Thanks very much. So my question goes to the Indonesia team. As to the last point around the NITAG core team and health economic working group, asking as a very biased health economist, what happens when there's non-agreement among the topics, terms of the decision? And the other one linked to the Nigeria presentation. So I understood that the NITAG and the other levels above were more problematic of. The NITAG has said this is a good thing to do. The other levels are probably discussing how before understand, and I thought that was potentially a good thing, other than maybe crowding the NITAG with problematic people. But then if there's no, as Alex said, maybe it's not feasible now, how do we justify an additional layer whose value becomes clear in terms of
Thanks everyone. I think this is a very interesting work and could be really impactful in the next 3 to 5 years, especially when we're on climate. My question is, how do you bring other key stakeholders in the country along? How do you start with that securing buy-in, movement, interest, and to all of the panelists, and to sustain that as well going forward? Because clearly when we're talking about budget efficiency in the scale of like a nationwide utilization program, we're talking about Ministry of Finance, Ministry of Planning, Ministry of Internal Affairs. Like, how do you even begin? Could you tell us more about this?
Maybe I will answer the last question first about how it can involve other stakeholders. In this case, I will use the experience of prioritizing new vaccines. During our exercise using the vaccine law, we actively involve many stakeholders, not only the Ministry of Health, but also involve key respondents from Ministry of Planning, Ministry of Finance. We also invited colleagues from our health insurance and other stakeholders. So using their feedback and their perspectives, at the end we made a consensus to make a well-established criteria that we use in terms of prioritizing new vaccines. So I think using that experience, I think in Indonesia we already active invite multiple stakeholders in decision-making process. And then Another question is about health economic working group in our NITAG. So I think in this case we did benchmark from Australia during one of our chair of NITAG visit to Australia. She saw that the decision-making process in Australia when they want to introduce new vaccines. Feedback from health economic perspective is very crucial. And then after her visit, and then we did a literature research, we did other benchmark from other countries, and then at the end, yeah, we developed this health economic working.
So thank you very much. So for us as a country, it's almost like similar. So in terms of the NITAG, so just like you said, so but for us, right from the beginning, we don't have a different group. So it's just like we want to have NITAG, and part of what they also assess is also the cost of that intervention, whether it's switch or new vaccine introduction. They look at it in the overall general perspective, looking at the vaccine efficacy, safety, dose efficacy, and they look at cost. So those are some of the things in this just integrated team that has also experts from the finance. But at the end of the day, it's just one decision. It's not like these are providing their own. They look at it all the buckets. So there is no any challenge around that. So in terms of engagement of stakeholders, so for every intervention, especially looking at it from the immunization point of view, so we have working groups. So working group, they are stakeholders, so and it's made up of government and all partners. Then if there is a major decision like this, we also have a wider stakeholders engagement. For instance, like for those decisions that we did around polio planning, we have two major stakeholders engagement, and we have those major stakeholders engagement. Apart from the health actors, we also have those that we call non-health actors. Those are like Ministry of Education, Women Affairs, and Social Development. We have finance, budget, so all stakeholders are part of. And fortunately for us as a country, we also have some additional working group like tax team. I mentioned we have new vaccine strategy tax team. That new vaccine strategy tax is made up of all the stakeholders that has a say in immunization and also delivery. Stakeholders from is it ACSM, that's advocacy, communication, social mobilization, which is a cross-cutting component of that. We have financing, their own part of it. So we have that expanded. Then we also have vaccine financing and accountability tax team. So the vaccine financing and accountability tax team has additional members from Federal Ministry of Finance, Budget and National Planning. Then we also have other expanded stakeholders that work on the general health financing from both government and partners. So we actually work as a team, so we have already wider stakeholders. And also experience from recently with the introduction of the HPV, we realized that HPV is a special vaccine, so you have to engage a lot of stakeholders. So that gave us an opportunity actually to expand our scope in terms of the involvement. Like that's why we have the Ministry of Education was in the proper perspective, because even the application, it has to be endorsed by the also Minister of Education, Minister of Finance, and then Minister of Health. 3 ministers has to endorse the application. So our system actually have an opportunity to have platforms where almost all the stakeholders are there. So recently also we engage CSOs, so civil society organization. They are like strongly in the picture now, and we have seen also their importance, especially around releases of the funds, because as government sometimes there is a limit to which office we can go and make noise. We can't even make noise. We just go and just lower our voice. But we get CSOs that can go and talk. Sometimes they can even go with media, say that we want to go to, so media will follow them. Of course, government will listen to them because they know the implementation. So we have a very wide way of engaging stakeholders, and whatever decision we take, usually we have a way also of ensuring that at least this information move to all the platform of all the stakeholders. So we carry them along, and we don't have to go around that engagement.
Yeah, so maybe to comment on the buy-in from the different stakeholders. So we have two types of stakeholders. So we have the technical stakeholders that are convened within the immunization technical working group. And these are the stakeholders who look at the day-in, daily activities that happen in the immunization program. Then we have the NITAG stakeholders, and typically decision-making within the NITAG takes time, any time between 6 months to 12 months, because the stakeholders are engaged in a sequence manner. So we do this so that we can be able to accommodate all the stakeholders that are important in terms of this decision making. So in terms of getting the buy-in, our process of decision making is longer, but again, at every step we need different stakeholders to be able to buy into the process. Thank you.
Great. I think we're at time, so I want to say thank you to our panelists and for sharing, country best practices and examples where they've already started to look at optimization, prioritization, and some really good food for thought, especially for countries who are probably either going to start this process or going to have to do this process a lot more often. So thank you, everyone.
Thank you.